Good afternoon and welcome to this briefing for the House Health Committee. I am Chair Heather Bagnall and here with our amazing committee. I ask for your patience if we encounter any technical or streaming issues. This briefing is being streamed on the Maryland General Assembly YouTube channel. And today we do have some virtual presenters. So if we have a delay in technology, please give us some grace. Panelists will control the transition of their slides. Now, before this briefing, all members were emailed a copy of each presentation. If you do not have these documents, please let committee staff know and we will send you a copy. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist. And please keep in mind to keep your questions brief. Also, this briefing is scheduled to conclude by 1:50, as we do have bill hearings beginning at 2 p.m. Today, the House Health Committee will hear a briefing from the Maryland Insurance Administration. And welcome back to our committee.
Good afternoon, Madam Chair. And my name is, everyone hear me? Okay. My name is Mary Quay, and I am the Associate Commissioner for Market Regulation and Professional Licensing at the MIA. And Commissioner Grant asked me to begin this briefing today. And the MIA has 3 topics to cover, and those would be the work group to study pharmacy benefit managers, or PBMs, the Mental Health Parity and Addiction Equity Act, or MAPIA, and Medicare Supplement, and Medicare Advantage plans. The MIA is the state agency that regulates insurance. And so the main activities of the MIA are to license carriers and insurance producers, monitor the solvency of carriers, review insurance policies, forms, and rates, investigate consumer complaints and allegations of fraud, and to examine the business practices of carriers. So the work group on PBMs was established by House Bill 813 of 2025. And the MIA and the Department of Health co-chair the group. An interim report was submitted at the end of 2025, and a final report with recommendations will be submitted by the end of this year. The charges to the group include review of both Medicaid and insurance topics, specifically those around reimbursement of pharmacists by PBMs. And the focus in 2025 was on insurance topics. And so the topics the work group discussed in 2025 included ERISA preemption, which we discussed in some detail, and we began discussions of specialty drug coverage and other state laws on the insurance side regarding where health plan members may purchase prescription drugs, and that often included discussions of specialty drugs. So ERISA is the Employee Retirement Income Security Act of 1974. It is a federal law aimed at protecting benefits for people, specifically pensions, but it also covers employee health benefit plans. And the important thing about ERISA is that it does preempt state laws that relate to employee benefit plans. And there is an exception for insurance products. So an employer's health plan may be governed by ERISA, but the insurance product, if they buy an insurance policy, is not. But if they self-fund, then the state insurance laws are preempted and do not apply as a rule. However, One thing that has happened in the last few years is that states have passed PBM laws that apply to PBMs even when they are working for self-funded plans. And this has been a topic of litigation, and that has gone up to the Supreme Court. And so after the discussion of the current state of laws and where litigation stands and what different federal circuits have decided, the group discussed and had some conflicting points of view as to how Maryland should act about promoting laws that would apply to PBMs when they provide services to ERISA plans. The first few said to wait and see what happens with the litigation. Don't risk getting tied up in lawsuits. Wait and see what the courts decide, and then we'll know what laws we can pass in those situations. Work group members who represented employers, and we had a number of additional stakeholders who represented employers, urged that state laws not be applied when they apply to self-funded plans. And then finally, other members asserted that pharmacists and patients benefit from these laws, and therefore they should be applied to as many health plans as possible. So the work group began discussion of specialty drugs, and this is a hot topic for the work group. We will continue to discuss specialty drugs into this year. And on the screen is the definition in the original statute. And this statute was passed with the intention of protecting consumers from very high co-pays and cost sharing when they pick up their medications. So if you had a $10,000 deductible and your specialty drug cost $12,000, you would have to come up with $10,000 to pick it up. And so the intent of this law was to limit what people would have to pay to get their medication. But one of the things in this law is that insurers could limit the pharmacies to their own specialty pharmacies and would not have to cover pharmacies that are in the local communities that they have not certified as specialty pharmacies in their network. And that has been a large part of the discussion around this, is what should the definition be so that community pharmacies can provide these services and medications to community members? There's also a site here for the Medicaid regulation. Medicaid has a similar definition and a provision about allowing members to go out of network and get their drugs at a local pharmacy. So this definition is very important to stakeholders, especially pharmacists. And specialty drugs can be very high profit items, and there were allegations that PBMs restrict specialty drugs so that they can retain the profits in the sale of these drugs. However, we heard from other stakeholders, from health plans and employers, who said that keeping this to a restricted network allows them to better manage costs and also promotes compliance by patients who get more support from the specialty pharmacy, and that they believe that this is important both for cost saving and for promoting their members' health. And so we will be talking about this in greater detail because we have looked at a number of other states' definitions, and we'll consider how it can be a more precise and more consistent definition across health plans. So the work group will also be looking at the effects of two laws, Section 151611.1. It prohibits a PBM from requiring beneficiaries to use a specific pharmacy if the PBM or a corporate affiliate of the PBM owns or has an ownership interest in the pharmacy, or vice versa. And again, specialty drugs are exempted, so they can restrict people to a specialty pharmacy for specialty drugs. And then Section 1612 of the insurance article prohibits a PBM from reimbursing a pharmacy less than the amount that the PBM reimburses itself or an affiliate that it owns. We had some mixed reactions from the work group about discussing these laws. Some felt that we should not spend a lot of time on them because of ERISA preemption and that these do not apply to ERISA plans. And others felt that it would be useful to discuss these and also to look for how we can have experts to advise us on the definition of specialty drugs, and so we can better craft that to be more relevant. But those are topics that we are carrying over through this year. And then our other topics for 2026, we will be looking more at the Maryland Medicaid program and how other states handle their Medicaid programs with regard to reimbursement to pharmacists. And to discuss reimbursement for pharmacists overall. And one of the things that has been discussed is what's called NADAC, and I don't recall what that stands for, but it is a common way to determine an average price. And then also the costs to pharmacies of contracting with different types of health plans, including commercial versus Medicaid. And so I can take questions regarding the pharmacy benefit group.
Delegate Kaufman.
I think one of the most harmful things that PBMs require of the customers is fail-first protocols, whereby you have to fail first on a cheaper medication before you get the actual prescription that your doctor prescribed. And so I'm just wondering if fail-first protocols have come up in the PBM work group discussions, and if so, what was said?
They have not come up in this context. It is a topic that the MIA has considered and will continue to look for when we conduct market conduct exams involving PBMs, especially those that are acting as the private review agent, which is the entity that can approve medical necessity requests. So the MIA is looking at that, but this work group is not.
Thank you, Madam Chair.
Thank you very much. I'm looking around to see if we have other questions on this briefing. And our committee manager, Alicia, also made me aware that we do have virtual panelists who are here to answer questions as well. Is that correct, Mary? Ms. Quay? Ms. Quay, do you want to proceed to the second briefing?
Of course. Okay, so the Parity Act, this is a complex area of law. At its most simple, it says that people should have the same access to mental health benefits that they have to medical surgical benefits, and that the limitations imposed by the carrier cannot be more restrictive. And this breaks into quantitative and non-quantitative treatment limitations. Quantitative would be fairly obvious, like your deductible and your copay, limits on the number of visits that you can have. Non-quantitative treatment limitations are a more complex topic because they include things like the number of providers in the network, the process to obtain prior authorization of services. And so they are something that we are looking at, but it's harder to measure. The Consolidated Appropriations Act of 2021 was a federal budget act that included some health plan laws. And it included the No Surprises Act, and it also included a provision that health plan issuers and self-funded health plans, so employers, had to prepare non-quantitative treatment limitation analyses and be prepared to submit them to regulators, including state regulators, on request. And the Federal Department of Labor had previously done a self-compliance tool for NQTLs, and this basically took the provisions of the tool and made them into a federal law for what employers had to do. And so the MIA conducted stakeholder meetings, and as a result, we put out a template instruction, selected NQTLs for reviews. This came about because of a statute, section 15144 of the insurance article, that mandated the filings with the state. And so we submitted an interim report. The primary thing that we found in that report in 2023 was that none of the carriers submitted analyses where we could determine substantive compliance with MIPIA. And so in 2024, there was emergency legislation that addressed some of those problems. And so in 2024, the new law required that instead of reports at the plan level, they are at the product level. And that's a kind of technical term, but it means basically instead of very small data sets, we have much larger data sets. And we developed standardized data templates for carriers to submit to show how NQTLs are applied in operation. We request not fewer than 5 NQTLs, and it gave us additional enforcement mechanisms. And so the NQTLs that we selected for 2024 are listed here. And so that's the prior authorization review process, prescription drug formulary design, provider including facility reimbursement, strategies for addressing provider shortages, and provider network directories. And so when we got the initial reports, we continued to receive reports that were incomplete and insufficient to determine substantive compliance. For the large carriers that you all know and think of when you think of a major medical carrier, we did up to 3 rounds of reviews of each of their filings. None of the initial reports were sufficient, but some carriers did submit sufficient reports by the end of the review after feedback from the MIA. And we found 3 reports that did in fact demonstrate compliance. So as compared to the earlier round of reviews, this was a big improvement, but there is a great deal of room left for further improvement. We also found that some filed sufficient reports but did not demonstrate compliance. And those areas were in provider directories, provider reimbursement, and addressing provider shortages. In 2024, the 3 federal agencies that enforce MIPIA issued final regulations. These had gone through public comment and were adopted. And these included steps for additional data requirements to show compliance in operation and new definitions. In 2025, the tri-agencies announced that they will not enforce the 2024 requirements. However, they have not formally revised or rescinded the 2024 prior rule or final rule, but prior MIPIA rules also are being enforced. And so we are currently in the process of issuing orders with penalties against carriers that failed to file complete and detailed analyses after the 3 rounds of feedback. 2 of those orders have been issued. One of the carriers has requested a hearing on that. And the MIA has also issued notices of noncompliance to carriers that filed sufficient analysis reports, but were not in compliance with MIPIA. And this is something that was in Maryland law. Section 15144 says that the MIA will give the carriers notice of noncompliance and 90 days to submit a compliance plan and reprocess claims as appropriate. And so that was found for 2 carriers with provider network directory problems, 2 carriers who had insufficient strategies or disparate strategies to address provider shortages. One was for provider reimbursement, and one was for prescription drug formulary design. And so they are still in their period to prepare and submit compliance plans. And so our recommendations that were in the report that we filed at the end of 2025 include adding provisions of the 2024 federal rules to Maryland law. We did not recommend adopting all of the provisions in the federal rules, but we felt that some would be a strong benefit to Maryland consumers. And that includes definitions of mental health and substance use disorder benefits that are consistent with current medical practice, requiring carriers to collect and evaluate data to assess the impact of the NQTLs on the relevant outcomes, and that would be part of the in-operation analysis of whether they are complying. And that data that shows a strong material difference in the access to mental health benefits as opposed to medical surgical benefits would be a strong indicator of noncompliance. And then finally, any material differences the carriers would have to explain and take actions to address. And so any questions about mental health parity?
Thank you so much. And I saw that Commissioner Grant has joined us. If you'd like to join the panel, you are welcome. But also, if you want to take a moment to catch your breath, that is also fine too. Associate Commissioner Quay has been doing an excellent job. So I see I have a question from Delegate Hill.
Thank you for the presentation. Can you get into a little detail about what the non-compliance looked like, including those who later complied? And what I'm really trying to get at is what, was it that, and the why? Was it too hard to do the compliance? There wasn't enough time? And then specifically, was it things like we just don't have enough providers to, what were the nature of the non-compliance and the ones that are corrected and not?
Because of the nature of NQTLs, it often came down to different processes. And so for I mentioned provider directories. They might have a process for medical surgical providers where they say, if you don't update your information, or when we follow up with you to verify your information, you never respond, we're going to suppress your name and you're not going to appear in the directory. But they might not have that on the mental health and substance use disorder side. So you might, we've all heard of the problems where people say, I called the providers on the list and they say, no, I don't take that insurance. Or they don't even, the phone number's not even working anymore. And so that would be a difference in the procedures that leads to that kind of an outcome. And so that's the type of thing that would lead to a violation there.
And so the ones who then come in compliance, they've changed it. In other words, you guys advise them and say, this seems to work in your other scenarios or with other folks, why don't you try this? And they adapt some new process and they then do a better job?
That is our hope, yes.
Thank you. Thank you, Madam.
And I recall this from our last session, but just for the edification of our entire committee and for some of our new members, can you just talk a little bit about the work with stakeholders around the 2024 and 2025 legislation, so we understand sort of the big picture of how we arrived here?
After our report in 2023, we met and had extensive meetings. Senator Augustine and you, Madam Chair, were both very involved in promoting coming together and building consensus around things that would improve enforcement. And we were really concerned about how we could get more useful reports and also be better able to enforce the law when we found issues. And so we had multiple meetings with all the stakeholders together and really talked through various ideas that had been proposed and things that we had suggested in our report. And so we came up with some tools, for example, being able to bill the carriers for time we spend on reviews after the first review. And that is something where even if the carriers came into compliance, or let me rephrase that, even if carriers finally submitted a sufficient report after feedback, we might decide, okay, we're not going to penalize you for that because we want to encourage you to submit sufficient reports. But we will bill you for the time we had to spend because you didn't do it right the first time.
Thank you very much. And I see I have a light from Delegate Taveras.
Thank you, Madam Chair. I just also want to highlight that while I feel things have incredibly improved with telehealth, it's also very challenging to find still the right person for you, because while the question I have is, you can call somebody you think may be a good fit, but these people may not be taking new clients. So that also diminishes your options, especially when you don't feel that there's a right diversity pool to select from. So, I mean, are you guys working on, how are you guys doing on the diversification options, if at all?
We have a separate unit that, well, it's part of the same unit, but we have separate laws that look at network adequacy. And so we address a lot of those topics through the network adequacy process. And then through this NQTL process, we looked at how carriers are addressing provider shortages. So if there is a shortage of mental health providers, are they addressing that as aggressively as they would address shortages of other types of providers? And also we looked at the accuracy of provider directories so that at least you don't have the frustration of calling too many people before you find someone who is actually in network and still practicing.
Thank you.
Delegate Gazzoni.
Thank you, Madam Chair. I'm just trying to get a little more insight into sort of, I guess, decision-making, because you note on, I don't know, whatever page this is, that the federal government's not enforcing the 2024 new rules, or the final rule, and are not going to be enforcing any actions for the failure to comply. And yet, a couple pages later, it appears that some of the provisions from the 2024 year federal rules have been added to Maryland law. So I'm just curious about sort of like, what were the decision-making processes on that, and what does that look like with regard to the federal not being in the same posture, I guess, as the state?
Go ahead.
Okay.
Unless you want me to start.
I may defer to the commissioner here because it is actually a bill that, one of our departmental bills to add those provisions.
Yeah. So the process of looking into what to incorporate in the departmental bill that you'll hear a little bit more later started before we knew the administration wasn't going to enforce the rule. It started with, here is a federal rule, what really makes sense for our enforcement in Maryland. And so I think Associate Commissioner Quay, working with Associate Commissioner Cooney, really did a long, thoughtful look at what provisions would actually help consumers and help our enforcement. There were actually provisions that we did not incorporate. And along that journey, then the Trump administration announced it was not going to enforce the rule. They haven't taken further action than that at this point, just that they're not enforcing. It's still on the books. And so what we took in is not the entire scope of the rule, but things, definitions, and then data requirements that are, I think, really important for our enforcement here in Maryland.
Delegate Rosenberg.
This may have been answered, but can we enforce the rule on our own? Or do we need federal? Or that's a question for the lawyers?
So if a federal rule isn't in effect, and I suspect it might be a little bit complicated, I don't have the code right in front of me, but I think what we're trying to do here is decouple from linking directly to federal references that can change and say, these are the definitions we think are really important for Maryland. If we just link to the federal rule and the federal rule changes or goes away, there's nothing for us in Maryland to enforce.
Okay, thank you.
All right, seeing no further questions, we'll conclude the briefing on mental health parity and addiction equity and move on to the Medicare 101, parts of Medicare and Maryland's role.
Come on up. Thanks so much, Madam Chair, committee members. It's a pleasure to be with you. I apologize for not being here right at the start of the briefing, but I think you were in excellent hands with Associate Commissioner Quay. So I'm Marie Grant, Maryland Insurance Commissioner. I'm pleased to have with me Patty Dorn, who's our Associate Commissioner for Consumer Education and Advocacy, and an expert on all things Medicare. So we wanted to take this opportunity to talk a little bit about the different pieces of Medicare. This is gonna come up in a few different places for you all this session, and talk about what's federal, most of it is federal, and then how we interact as a state. Oh, how do I, oh, there we go. It's just slow. Okay. So Medicare is a federal health coverage program for folks who are age 65 or older, under 65 with certain disabilities. folks who are any age who have end-stage renal disease, and also folks who have ALS and Lou Gehrig's disease. And there's different parts of Medicare that are important to understand. So Part A is hospitalization. This is referred to as hospital insurance or inpatient insurance. It's funded by payroll taxes. So most folks with personal or spousal work history and paid into Social Security, you don't pay for Medicare Part A. That's something you qualify for when you turn 65 in most cases. Covers care in a hospital, some costs of skilled nursing facilities and home health services, as well as hospice care for the terminally ill. And to be eligible, generally, you need to be 65 or older, lawfully present in the US, and have worked the required amount of time. Anything you want to add here?
No, go ahead. Go with Part B, and then I'll add something.
Okay. Great. So Medicare Part B is referred to outpatient insurance. And together, Part A and Part B work together as traditional Medicare or original Medicare. So Part B is funded by Part B premiums and general revenues from the federal government. It covers things like doctor services, lab tests, medical equipment, ambulance services, prevention and wellness screenings, orthotics and prosthetics, and mental health services. There is a permanent penalty for late enrollment in Part B, which is 10% of the base premium for each year you delay enrollment. I'll turn it to you.
All right, so yeah, with that penalty, they want the people who are qualified for Part B to start participating. So I think this is a good place to stop and talk about how this fits into the big picture of Medicare before Marie starts talking about more details with regards to Medicare Advantage and Medicare Supplement. So she just talked about Medicare Part A and Medicare Part B. So those together cover about 80% of the costs of a Medicare beneficiary's healthcare costs, except for prescription drugs, Medicare Part D. So A and B are covering about 80%. So there's still the 20% that needs to be covered in another way. Consumers, Medicare beneficiaries are going to get those things covered in a few different ways. Number one, some people that are low income are going to get that covered under Medicaid. So that takes care of part of this population. Part of this population is going to get that 20% covered through retiree benefits. For state employees, when they retire, they're going to get that covered, federal employees, et cetera. And then that leaves the rest of the population. And the rest of the population is going to focus on Medicare Advantage or the Medicare Supplement in order to cover that 20%. So that might clear it up a little as we get into a little bit more information about Medicare Advantage and the Medicare Supplement.
Thanks, Patty. Okay. All right, yes, that's a great lead into what we call Part C, or Medicare Advantage. So Part C consists of Medicare Advantage plans that are offered by private companies under a contract with Medicare to provide Parts A and B. These plans may offer Part D coverage, pharmaceuticals, which we'll talk about in a little more detail. So many of these plans offer additional benefits or supplemental benefits for things that aren't traditionally covered by Medicare Parts A and B. So things like vision and dental, not offered under original Medicare, often offered under Medicare Advantage plans. In most cases, patients are still paying their Part B premium. They may have some additional premiums, deductibles, and copays. It varies by the company and the plan that you're enrolled in. The other thing before I talk about the decision to choose Medicare Advantage, because it's an important one, Medicare Advantage plans also typically have networks, right? Original Medicare does not have networks. Medicare Advantage plans typically do. Original Medicare also has very little utilization management and things like prior authorization. Medicare Advantage plans have I would say, pretty robust utilization management and prior authorization. I'm going to let you talk about this slide, if that's okay, Patty. Just about the choice to enroll in Medicare Advantage.
Okay, so, yes, to Marie's points, the pre-authorization is one reason that someone might choose a Medicare supplement plan. So A and B covering that 80%. This particular beneficiary that we're talking about doesn't have Medicaid and doesn't have a retiree benefit. So they're deciding Advantage plan versus Medicare supplement. So with the Advantage plan, there are those pre-authorizations that they're not going to see if they choose the Medicare supplement product. The Plan C, the Medicare Advantage, acts a lot like the plans that say, you know, we get while we're working. Everything's all bundled together. The Parts A, the Parts B, the supplement, and the D usually. And again, you're going to see those networks, and those networks you're not going to see with the Medicare supplement. With the Medicare supplement, a Medicare beneficiary can go to any provider who accepts Medicare, who is, you know, presumably taking patients. And they are limited to that network with Part C. Another difference is going to be cost containment for the beneficiary. It's a little bit more predictable with the A and B and the Medicare supplement to estimate what the costs out of your pocket is going to be for the next year versus the Medicare Advantage plan.
And so if a Medicare beneficiary, though, chooses a Medicare Advantage plan when they're first eligible, and they're unhappy with that in the first year, within that first year, they can still go to a Medicare supplement policy without underwriting. However, if they then decide they're unhappy with their Medicare Advantage after 12 months, generally they can only be able to purchase a Medicare supplement by going through underwriting.
I can expand on that a little bit too.
Absolutely.
All right, so with the Medicare supplement, a beneficiary has that first 6 months after they're eligible for Part B to purchase any of those plans that they want, any plan that they want without underwriting. And after that, the door closes and they may not get another opportunity to purchase a Medicare supplement without underwriting. When they first enroll in a Medicare Advantage, so in the first year, if they were to choose the Medicare Advantage plan over the Medicare supplement, and they change their mind in that first year, they are going to get 63 days. They're going to get a special enrollment period of 63 days to go ahead and choose a Medicare supplement.
All right, I'm going to talk a little bit about Medicare Advantage here in Maryland. I know that you all had a very comprehensive briefing on all things ahead and touching on Medicare Advantage during that time last week. But just a little bit from our perspective, Maryland has had historically low penetration rates of Medicare Advantage than nationally. Some of that may be due to our unique hospital rate setting system. It's not as profitable necessarily for Medicare Advantage plans to operate in Maryland. Some of it may be our demographics. We have a lot of federal and state retirees. And so some of that may just be who we have here in Maryland. But our market share, our penetration of Medicare Advantage plans with our seniors is definitely growing. The numbers I have, and I think this includes employer groups, we had 13% penetration at the end of 2020. We were over 25% in 2025. So again, relatively small proportion. In some parts of the country, it is half or over half, but definitely growing over the past 5 years. So total enrollment in Medicare Advantage plans in Maryland as of September 25 was close to 300,000 folks. And then approximately 47,000 current Medicare Advantage beneficiaries in Maryland who had Aetna and United plans didn't have their 2025 options in the market in 2026. So I think, as you all know, this has been the topic of extensive discussion. There are some real benefits to having Medicare Advantage options in the market for our seniors. And there were a couple of recommendations that the HSCRC is taking up after interagency discussions this fall as part of the interagency working group and receiving public comments from carriers, consumers, hospitals, health systems, et cetera. So for Medicare Advantage, there's a solution that seeks to reduce hospital costs for qualified MA plans and maintain hospital funding by increasing commercial rates beginning in calendar year 27 and then phasing up. So once fully estimated, it's estimated to increase overall commercial rates by 0.65%. And then there's certain criteria that plans are going to have to meet to access this support. So at least 50% of the MA beneficiaries in the H contract will have to reside in Maryland. At least 5,000 of the beneficiaries, or 20% of MA beneficiaries residing in Maryland, need to be in counties with high proportions of underserved beneficiaries. And there's also minimum quality ratings in the federal government's Quality Star program that will need to be maintained. So, Part D, on to Part D. Part D is medication coverage. This is provided through private companies, either as standalone plans or as part of the Part C Medicare Advantage plans. There's no pre-existing condition clause. Part D plans have to accept anyone who's eligible. There may be a permanent penalty for late enrollment in a Part D plan, which I'll turn to Patty to expound on. And then different plans have different costs and formularies or a drug list.
Yeah, and just like with Medicare Part B, you can and will likely be penalized for late enrollment in Medicare Part D. So if you're qualified for Medicare Part D, the expectation is that you start on Medicare Part D, or when you do, later, you will receive a penalty of 1% per month for every month that you were not enrolled in Medicare Part D, and that penalty will continue on for the remainder of your life. So if it was a 20% penalty, every year you'll be paying 20% more for your Part D premium.
All right. So, and now we want to talk a little bit more in detail about Medicare supplement insurance, which actually, as a state, and leading into a bill hearing later this afternoon, we do have an increased role in regulating. And so do you want to talk about this slide, Pat?
Sure, yeah, I can take this. So we're going to talk about the Medicare supplement. All right, so I've done a lot of these Medicare presentations, and so I'm sorry for repeating myself, but I always feel like it's better to do that. Remember, A and B is going to cover that 80%. And this Medicare supplement product is going to come in and essentially it's covering the 20% that Medicare Part A and B doesn't cover. When somebody chooses original Medicare, A and B with a Medicare supplement, they are purchasing a standalone Medicare Part D plan as well. Medicare supplement is purchased from private insurance companies. There's 12 standard plans in Maryland. And there's that 6-month Medicare open enrollment period when you sign up for Part B, where you can purchase any Medicare supplement plan in your state without underwriting.
The other thing I'll just mention before we go to the next slide is I think colloquially we often call these products Medigap. so Medigap, MedSup, Medicare supplement, all the same thing. So a little bit about what we regulate. We regulate insurance policies issued in Maryland, including Medicare supplement. We don't regulate Part A, Part B, Part C, or Part D, except for solvency and producer conduct. And so, for example, we do a review of MA plans and sign off on solvency before they submit their bids to CMS. But CMS is actually setting all the standards for those plans. For Medicare supplement policies, we review policy forms, we review premium rates, and complaints from consumers. All right, can I turn it to you?
Yeah, sure. Madam Chair, are we okay for time? I know we're... I'll get through this part quick. So just a brief explanation about enrolling in the Medicare supplement. You have that first 6 months when you become eligible to enroll in a Medicare supplement without underwriting. So they have to accept you, and they have to offer you the best price for that product for your age. It is also a Maryland state law that those who are eligible for Medicare due to a disability are also offered certain plans without underwriting. And then there's a situation called the special enrollment periods. Those are 63-day periods in which you can enroll in a Medicare supplement without underwriting. And usually that is because you lost insurance through no fault of your own. So for example, someone who does have a plan through their retirement benefits, and those retirement benefits go away through no fault of their own, in most cases, they are going to qualify for 63 days to purchase a Medicare supplement without underwriting. Another example is somebody who's in a Medicare Advantage plan, and that Medicare Advantage plan stops servicing their area. They're also going to get 63 days should they want to choose a Medicare supplement plan without underwriting. And so there also are those special enrollment periods. And then there's the Maryland Supplement Birthday Rule. So this went into effect, I believe, July 1st of 2023. And it expanded access. It expanded the ability for a Medicare supplement policy holder to switch plans without underwriting. So before the Medicare Supplement Birthday Rule, I will say, having worked closely with seniors, choosing a Medicare supplement plan was really stressful because most Medicare beneficiaries choosing a Medicare supplement plan felt like they had one chance, and they kind of did. You know, you choose the plan, and if you're going to change your mind, then you're going to go through underwriting. What the Medicare Supplement Birthday Rule does is it allows Marylanders who already have a Medicare supplement plan to switch to another Medicare supplement plan during their birthday month. So what the birthday month means is the day of their birthday and the 30 days after their birthday. Now, they can only switch to plans of equal or lesser value, and our actuaries have defined what equal or lesser value is, and we have a matrix of those plans. But it allows a lot of opportunities for Marylanders to shop for a better rate or switch to a plan that makes sense to them, something that they didn't have before. And then I know we're short of time, so our last couple slides are just talking about places where Medicare beneficiaries and those soon-to-be Medicare beneficiaries can...
You are fine on time. This is
okay.
really important that we all understand it, because Medicare is the
Beautiful.
space that we don't have a lot of regulatory authority. So take your time,
Okay,
because
'cause
I
I
want to
can
make
do
sure our
this.
members understand, what we're talking about.
Thank you, Madam Chair. I can do this all day.
Yeah.
All right, so SHIP, I think a lot of you are aware of SHIP. The SHIP program serves Maryland Medicare beneficiaries and those soon-to-be Maryland Medicare beneficiaries. There's a SHIP program in each county in Baltimore City, and it is a great resource for learning about Medicare, making decisions about Medicare, or a great place for Medicare beneficiaries to go in Maryland when they just have questions. Under the umbrella of the Maryland Insurance Administration, we also have a program that can assist called the Health Coverage Assistance Team. The Health Coverage Assistance Team is like a no wrong door Marylanders' health insurance program. And so essentially, we do only have jurisdiction over a limited percentage of the health insurance policies sold that Marylanders have in the state of Maryland. But the Health Coverage Assistance Team assures that anyone who comes to the MIA who has a health insurance related complaint is going to get to where they need to be. And sometimes that is SHIP. We're going to help Medicare beneficiaries if they have Medicare supplement related questions, or if it's just a general Medicare question. Other than that, we're going to get that person over to the SHIP, the right SHIP for them. So if they're in Charles County, we're going to get them over to the Charles County SHIP, et cetera. And we're not going to just drop them off. If they would like us to stay with them, the specialist from the HCAP program is going to check in with them and make sure that their situation is in fact being resolved. That is, I think,
That's it?
that is it. So I guess we're ready for questions.
Go ahead, Madam Vice Chair.
Thank you. Thank you, Madam Chair. And I apologize that I'm late getting here. I promise I am going to watch what preceded you, and I bet I will send you a question or two. But for now, the first thing I'd like to say is the HCAT is an example of how government can work. And I want to thank you all so much, because it is a place that I frequently send constituents to who are looking for support. And everyone tells me they helped. And so you're terrific on that. And on the, when a Med-Sup plan like Aetna is no longer going to be available, who's responsible for notifying people of their window to choose another plan? Is it the carrier? Is it MIA? How do people learn that because that's a short window, a relatively short window of time, and I'm concerned that people don't get adequate notice.
Yeah. So it is, did you mean Med-Sup or Medicare Advantage, Madam Vice Chair?
I meant the SUP, Med-Sup, right.
I think in both cases, it is the carrier that has the obligation to let folks know if a plan is leaving the market. And then there are various notifications that need to go out for folks. Do you have anything to?
Yeah, I mean, only that if someone purchases a Med-Sup plan and that Med-Sup carrier stops offering new Med-Sup plans, they're going to carry on with their original plan. I think it would only be in case of a bankruptcy or something along those lines with regards to the Med-Sup. But with regards to Medicare Advantage, again, regulated by CMS, they have rules that they have to follow with regards to notifications. They will be notified by their insurer, and from what I have seen, usually that notification, if it's going to end at the end of the year, that notification is usually coming in September, but I'm not exactly sure how many days they have to notify them in advance.
Yeah, maybe I'll just add to, with regard to Medicare Advantage, because this was something I learned new this year. There's the notification in September. There is open enrollment for Medicare Advantage in the fall. And then there is also a special enrollment period, I believe, for those folks who lose plans, starting the day they lose the plan. So right now we are actually in a 63-day enrollment period. So for those folks who are on United plans, for example, say they didn't get the notices over the fall, say they went in and had trouble right now, they could still go get another Medicare Advantage plan or a Medicare supplement plan without underwriting for a 63-day period starting from January 1.
Right. So if an Advantage plan were to leave and they receive their notification, they're leaving at the end of the year, they receive their notification in September, most of the beneficiaries are going to use that Medicare open enrollment period to choose another plan. But if they did not, technically their 63 days actually starts on January 1st.
I want to make sure that there's some accountability for notification, which I think is important. And the last question, Madam Chair, is under the birthday rule, can individuals get support from navigators? Is there a network of navigators that can do that, or do they have access to them?
So we publish a Medicare supplement rate guide, which has all the companies offering the Medicare supplements and their rates and the different letters that each is offering. And they are encouraged, they can certainly call the HCAP program for assistance, but there aren't specific navigators for the Medicare supplement birthday rule.
Thank you. Delegate Shalega.
Thank you, Madam Chair. We had a bit of a discussion about the cost shifting in the briefing in the joint hearing room, so I'd like to drill down on that a little bit further. And so is this going to be the program they talked about that was 87 million plus 87 million? Is that the cost shifting?
I believe so.
So
Actually.
has that already been approved, or is that in the works, or where are we with that?
So it is now with the Health Services Cost Review Commission. What we are doing right now is determining who is eligible for that program. I think if we haven't sent the questionnaire out to our carriers, it's imminent, asking them about the rules. And then it will need to be a decision that the once we determine who's eligible, it'll need to be a decision by the Health Services Cost Review Commission before July 1 to build in rates for the following year. So it's not done,
Okay.
it's on the track.
Okay,
Yeah.
because I did the math on it, and it's $1.3 billion over 5 years. $1.3 billion. When you add up all of those, where you finally get to 435 million, I mean, that's a significant tax on private insurance. Your paperwork says increase commercial rates by 0.65%, but the information that we got in the joint hearing room said it will increase the premiums by 1.8%, which is double what you're estimating.
So I think, and would love to talk to you offline about the math. I think we were just talking about Medicare Advantage here. There are other dynamics with cost shift as well that is all playing into this that might have been part of the presentation. So if okay with you, I would like to talk
I
a
will
little
take
bit
it offline,
Yeah.
but finally,
Yeah.
how, is this on top of the $100 million hospital tax?
In terms of the assessment that helps fund Medicaid on hospitals?
Right.
Is that what you're referring to? I believe this is on top of that. That's my understanding.
Okay, and, sorry, but is there a federal rule about you taxing health insurance that disqualifies you?
There is a Medicaid provider assessment rule that says it doesn't apply so much in terms of our premium taxes on insurers generally. What it gets into is at what point can you stop getting a federal match for your assessments on health insurers and MCOs. But yes, my understanding is that this is an administration that's very concerned about provider tax challenges in states and is looking closely at their levels. So I'm not sure, Delegate Schlega, that that is an issue for Maryland, given our current state of play, but I know it is something our Medicaid program is very sensitive to and looking at.
All right, thank you. I'll look forward to getting that math and sharing it with all of
If we
you.
can share it with the full committee. Thank you. Thank you so much, Delegate. Delegate Taveras.
Aye. Good? All right. Thank you. Thank you, Madam Chair. So I want to say thank you for the presentation. I get a lot of my information from last week tonight on John Oliver, who did an expose on this. I like my information with a spoonful of comedy. So, but with this, I think it's very important that that we ask because I like the idea of the birthday, yes, policy switch. But, and I recognize that it could be of equal value or lesser value, but does that also include the services that are being rendered for the need of the person?
Yeah, so the equal or lesser value is based on the total value of the product. And so the richest, there's certain Medicare supplement products that cover more out-of-pocket and certain products that cover less out-of-pocket expenses. And so that's what that is referring to. I might not have understood your question.
No.
Okay.
I recognize that it's a cost issue, but
Yeah.
what of the actual services that person actually may need?
Okay, got
Yeah,
it.
they may want to pay less,
Okay.
but they may have greater needs.
The Medicare supplement pays after A and B. So they pay the part that's not covered under A and B. So if A and B is not covering it, if it isn't covered under Medicare A and B, it's not covered under the Medicare supplement.
So they're basically out of.
Yeah, with regards to the Medicare Advantage plans, they do have bells and whistles that in some situations cover things that are not covered under Medicare A and B, but that's not how the Medicare supplement works.
Delegate Rosenberg.
Does the new federal law affect eligibility for Medicare Advantage or in any way affect the operation of the program?
Are we talking about the big bill?
Yes.
Thank you, Delegate. So I don't think there are major, it's a big bill, so I don't think there are major provisions in that bill. I will say the federal government just released a proposed rate notice. It's not final, but proposed, I think, just earlier this week, that essentially flat funds Medicare Advantage plans for 2027, and then really clamps down on risk adjustment practices by Medicare Advantage plans. And so you may have seen, I think there's a lot of articles this week about sort of how that will impact plans nationwide. But that's not in the big bill.
Can you describe the effect it would have for those of us who've been reading bills instead of a newspaper article?
Yeah, absolutely. So I think, and it's going to depend on who you ask, Delegate. I think it does two things. When you flat fund an organization, and we just generally in the context of medical inflation, I think it makes them need to put a much finer pencil. It really does impact how they're going to operate those plans. And the second thing I said about risk adjustment is, for better or for worse, Medicare Advantage plans have done a lot to upcode essentially, make sure they're capturing all the diseases a person might have so that they can charge a higher risk score essentially from the federal government. And the proposed rate notice that just came out this week really impacts how they can do that. So essentially, if I were just to bottom line, they're going to get a lot less money from the federal government, and that's going to make it a challenge for them going forward.
Thank you.
Delegate Hill.
Thank you, Madam Chair, and thank you for this lovely presentation. So we administer Medicaid, and the only role we have with Medicare is in the supplementals, right, the Medigaps. For the Medigaps, do any of the qualifying life events that we see with other insurance policies come into play in terms of people switching and move where it's just once a year you can go wherever you want if you have a Medigap? I know you talked about going from Medicare Advantage to Medigap, but what about in the world of Medigap in and of itself?
So most of the special enrollment periods with regards to the Medicare supplement are in situations where someone lost a different kind of insurance through no fault of their own.
Okay, so things like the qualifying life events that we see, like pregnancy, change of residence, maybe the death of someone, that kind of stuff, that doesn't really tend to apply, or people have that same ability in mid-year to change if some qualifying life event occurs?
No, I mean, for the most part, it really is losing another insurance, be that Medicaid, be that, retiree benefits, be that an Advantage plan that left, or, theoretically, if your Medicare supplement was no longer available as well.
Okay. And then can you give us just a little bit about what are we reading, even though we don't manage it, about the problems with the Medicare Advantage programs that have different ones being challenged by the feds and being threatened with not being allowed to go on? What is the problem with those programs as you understand it?
Delegate Hill, I can start with that, and then Patty, if there are specific complaints you see in the HCAP program relating to Medicare Advantage, maybe we can add on. So I think some of the federal investigations in recent years have been about improper payments or risk adjustment, essentially questionable. And I think a lot of these are still in litigation, so I don't even want to say it's a done deal. But I think there have been a lot of concerns identified that perhaps Medicare Advantage plans nationally have collected overpayments from the federal government, potentially for care that they didn't actually pay for just by looking at the risk adjustment. Some of the other issues I think that people have asked about with Medicare Advantage have been networks, right? Those are the kinds of things people don't understand, that always when they get a plan that means they're trading off for a more restrictive network in prior authorization. That is, you are trading off, again, maybe lower costs, maybe additional benefits, but then trading off for that network and prior authorization practices. Are there any specifics you
Yeah, I mean,
HCAP?
coming from the consumer's perspective, we certainly talk to consumers about their frustrations with Medicare Part C, with the Medicare Advantage. Although for the most part, I mean, we're working with SHIP on these. SHIP takes the lead with Medicare Advantage. But the Medicare Advantage plans can be frustrating for consumers because those plans can make changes every single year. And so you might see your provider leave for the following year. You might see significant changes in your out-of-pocket expenses. There can be surprises. It's common that a consumer has a zero premium Medicare Advantage plan. There's usually at least a few available to Marylanders, but that zero premium Medicare Advantage plan might come with $350 per day hospitalization for the first 9 days, things along those lines, that the consumer didn't go too far into the situation and understand what those out-of-pocket costs were going to look like. And so, yeah, provider networks, that's a frustration. Certain plans not being available the next year, and it's kind of always this churn every single year during open enrollment. Those who choose the Medicare Advantage plans kind of need to be on their toes because they need to be looking at what their plan is going to look like next year and considering if maybe a different plan does make sense for them. That is a lot different than the Medicare supplement, where you do have people who tend to, in some cases, somebody chooses a plan when they're 65 and they keep that plan for the rest of their life. And even if they do utilize the birthday rule to switch, oftentimes they're just switching from, say, a G to a G, a plan that they like to another plan that they like at a slightly lower cost. But the plan itself, they understand. It's the exact same plan. A G is a G is a G, regardless of the company that is offering it. So that can be a little bit easier. But yeah, we do see the frustrations with the Medicare Advantage plans. It is hard for seniors and people as they age to stay on their toes and make these decisions every single year.
Yeah, I just, before we leave that, and sorry, Madam Chair, because I feel like I just jumped in again. But there are clearly plenty of folks who like Medicare Advantage plans for the reasons we've talked about, right? And clearly they're a growing presence in Maryland.
Okay, and then I want to make sure I'm also correct about the other distinction. And I think of the Medigap or supplementals as like the AARP insurance, which, pretty common, people hear that advertised. With a Medigap program, Medicare determines your benefits. The 20% that rolls over, your Medigap doesn't get to argue about. They don't get to discuss your whatever. Medicare says, we're covering this, you owe that. The Medigap says, yep, here's the money, correct?
Correct.
With Medicare Advantage, Medicare National may say it's covered, but the Advantage can say, we don't. That's when you talk about pre-authorization. You've got to go through additional hoops. They can deny things that someone on generic Medicare might be able to get. They control more of what you're allowed to get. And so they don't automatically just cover because they become primary to Medicare. They become Medicare. Is that fair?
Yeah, Delegate Hill, that's a great way to think about it. They still have to cover everything that's in Medicare, but there may be more steps and demonstrations of medical necessity that a consumer needs to go through.
Okay, thank you.
Delegate Riley. Well, I don't see any more lights. And thank you so much for this comprehensive, these comprehensive briefings. It is now 2:20. We're going to go ahead and conclude the briefing. We're going to take a 10-minute break, so we'll come back at 2:30 for the start of our bill hearings. Go ahead and take us down.